I'm going to make some changes. Actually, it's pediatric benign hematological disorders during the COVID-19 pandemic, or what is the impact of COVID-19 on pediatric hematology diseases. Actually, since the start of this pandemic, what's published on COVID-19 in children is not so many. Although all physicians caring for immune suppressed patients are actually very caring or concerned about the effect of this virus on immune suppressed patients. The hematological manifestations as a part of the multi-system affection of COVID-19 is a very important part of this disease. COVID-19 infects cells via attachment to the angiotensin converting enzyme 2 receptors on the cell membrane, which will result in activation of macrophage endothelial cells, the coagulation pathways, and so resulting in what is very famous lymphopenia, neutrophilia, thrombocytopenia, increased acute phase reactions, and so on, what is very well known as the COVID-19 cytokine storm. What is this COVID-19 cytokine storm? There is actually a burst increase of some inflammatory cytokines, most important of which is interleukin 6, also interleukin 12, 18, interferon alpha and gamma, transforming TGF-beta, which will result in a marked increase of the acute phase reactants like ferritin, LDH, CRP, ESHR, PT, PTT, and so on. And please don't forget the rise also of serum CD20, which is a hallmark for the secondary or the viral-induced HLH. Let's start by one of the main immune compromised patients of our patients with aplastic anemia. How patients with aplastic anemia are affected by the COVID-19 infection. The most common or most frequently asked questions, do aplastic anemia patients have higher susceptibility to be infected with the COVID-19? And if they are infected with the COVID-19, are they going to manifest more severe forms of the disease? And what about the newly diagnosed aplastic anemia patients? Can we give them immune suppressant treatment, or we can't? Okay? Let's start by the COVID-19 lymphopenia. COVID-19, the lymphopenia is a hallmark of COVID-19, and it's either due to the attachment of the virus to the AS2 receptors on the lymphocyte cell membrane, which will result in lymphocyte lysis, or due to effect of the inflammatory cytokine storm, which will result in lymphocyte apoptosis in the bone marrow. On the contrary, COVID-19 is there is neutrophilia, which is either again to the hyperinflammatory state or due to an imposed bacterial infection. But what's more important than just to see in the CBC there is neutrophilia and lymphopenia is to calculate the neutrophil lymphocyte ratio. It shouldn't be more than 3.13. If more than 3.13, that is a very critical marker that denotes a much poorer and severer disease. On the contrary, like what have been mentioned in the hemoglobinopathies, that the higher iron level is protective against COVID-19. It has been proven that the immune compromised state of our patients through the hyperinflammatory state will make a paradoxical effect and may be more protective in disease manifestations. That is a very good point, okay? Anyhow, how I am going to manage an aplastic anemia patient is according to the severity of the condition. If the ANC is more than 200, then I'm going to go as usual for the erythrothrombobag and cyclosporin and postpone the ATG and bone marrow transplantation. But if in the super severe cases of aplastic anemia, where the ANC is less than 200, okay, carry the risk and go on for ATG and bone marrow transplantation. That is a very important point, that the timing of relapse after viral infection is not established yet. And so a longer follow-up is to be taken in consideration. What about the secondary or the virus-induced HLH? We have to put this in mind because under recognition or negligence to look for CD20 as affected by the hyperinflammatory state, which will result in multiple organ failure, this is a point that I should put it in consideration. Now moving to the second benign hematological disorder we face as the ITP. How patients with immune thrombocytopenia, when they are infected by COVID-19, how I'm going to deal with this condition. It's very well known that COVID-19 itself causes thrombocytopenia, either due to decreased production, apoptosis of the megakaryocytes in the bone marrow, or due to production of autoantibodies against the patient platelets. That's to make it more clear that both pathways we read at the end to thrombocytopenia. So for a patient with ITB, immune thrombocytopenia, there are a lot of pathologies when this patient is infected with COVID-19. There is a lot of pathologies or a lot of etiologies I have to look for. Like, for example, if the patient gets a DIC, sepsis, thrombotic thrombocytopenic purpura, TTP, if it is thrombocytopenia due to heparin induced, okay, or if there is a coincidence of another autoimmune disorder. In any one of them, I have to make the good laboratory parameter indicative of the cause of this thrombocytopenia. But if the patient of ITB experience a dramatic fall of platelets, that I have to consider that it is thrombocytopenia secondary to COVID-19. How I'm going to handle this patient of ITP while infected with COVID-19? It depends whether he is an acute ITP or chronic ITP. It depends upon whether he is in a stable condition. If he is in a stable condition, I'm not going to do anything, okay? But if he experience, for example, severe active bleeding, he is an acute ITP and experience severe active bleeding, there is marked drop of the platelet count, I may add steroids. I may use an alternative TEPO agonist. Of course, use an IVIG. In the chronic ITP, if the patient he was in a stable condition and then started to be in serious thrombocytopenia, I may add another TEPO agonist. I may try to add steroids also, but I shouldn't taper the immune suppressant. Anyhow, this is how what is the best management for ITP when associated with COVID-19. Of course, number one, the IVIG by the normal dose, and the TEPO agonists, of course, okay. Plus or minus adding short steroids and tranexamic acid. And why I shouldn't go for tranexamic acid? Because of the thrombotic complications of COVID-19. I can use it except when I can use it when I really need it, okay? For patients who are chronic on immune suppressants, of course, I'm going to continue on immune suppressants except for the rituximab. It is very dangerous to keep on with rituximab, okay? This is again a very commonly asked question about patients with ITB. Are we going to vaccinate them with the COVID-19 vaccine? Actually, what is written in literature is again very scarce because whether this vaccine will act like an active virus and cause more decrease of the platelet count, I cannot answer this question. But what is answered well is that if the patient have previously experienced drop of the platelet count after the MMR vaccine, then of course I wouldn't vaccinate him again with COVID-19. What about the autoimmune hemolytic anemia? Actually, for autoimmune hemolytic anemia, it was found interesting that the red cell membrane anecrin 1 share 100% identity with the COVID-19 surface glycoprotein spike. That's why in COVID-19 can trigger autoimmune hemolytic anemia in any healthy child. Any healthy child. Of course, if the child is predisposed for autoimmune hemolytic anemia, but even in very healthy child, if he experiences autoimmune hemolysis, I should look or search for COVID-19. This is CBC showing microspherocytosis and so on. How to manage autoimmune hemolytic anemia? By, of course, corticosteroids, again, IVIG, rituximab is very dangerous, and we have to be very hesitant to use it in acute autoimmune hemolytic anemia. What about the COVID-19 associated hypercoagulability? This is a very famous part. I'm going to speak very short on this because I know that you are going to cover this issue very well. It is just through the overactivation of the complement system, the coagulation system, and what's more important, the NET, or the neutrophil extracellular trap. Endotheliitis will lead to overactivation of the complement system, then followed by both intrinsic and extrinsic coagulation pathway activation, and the neutrophil extracellular trap, or the NET. This NET are the neutrophil antimicrobial proteins released as antimicrobial proteins, but the problem is that they will activate both the coagulation pathways and also provoke activation and trapping of the platelets. How to manage? Of course, by anticoagulants. Okay. Low molecular weight heparin is definitely better than unfractionated heparin for fear of the thrombocytopenia induced heparin and more feasibility of use of low molecular weight heparin. Extended prophylaxis is to be put in consideration. For vitamin K antagonist and direct oral anticoagulants, they show fluctuations of therapeutic level, and but sometimes I may need to add the rivaroxaban or petrexaban. This again, a very common question to be asked: is vitamin K antagonist and heparin can be used during breastfeeding? Yes. This is about the vaccine-induced thrombocytopenic purpura, thrombotic thrombocytopenia. Of course, if the platelet count dropped markedly within 4 to 28 days after receiving the vaccine, I should look for D-dimers and search for this pathology. This is my take-home message, that mindful utilization of diagnostic tools is very important for critically ill patients, and close monitoring and high index of suspicion will be very beneficial for at-risk patients. But what is as a good thing to say it in my last slide for my presentation is that the favorable outcome and lower than expected incidence of COVID-19 complications in immune-compromised patients led scientists to think that these immune modulatory drugs can make a beneficial rather than harmful effect on COVID-19 infection. Please stop COVID-19, and thank you.